This is diabetes in 10 minutes. So what is diabetes? Diabetes is an inadequate response of the body to manage blood sugar, and there are two major types. First type is type 1 diabetes, where the body doesn't make enough insulin. This occurs in less than 10% of people, and while it can develop at any age, is typically presenting when patients are sick in the hospital at ages less than 30. And these patients must take insulin in order to supply their body with a system to respond to their blood sugar. The more common form of diabetes is type 2 diabetes, where the body doesn't respond to insulin properly. This occurs in greater than 90% of people who have diabetes. And while it's more common over the age of 45, it's becoming increasingly common with people as young as teenagers. And these patients may need lifestyle changes as well as medications in order to manage their blood sugar. So, how do we diagnose diabetes? Well, type 2 diabetes, the most common form, is typically diagnosed using an A1C greater than 6.5%. But there are other ways that we can diagnose this as well. One option is to do a glucose tolerance test, where you drink a lot of sugar and then you check their glucose 2 hours later to see if it's above 200. Another option is to do a fasting glucose test. And if you have at least two abnormal values, whether it's the same test or multiple tests, that diagnoses someone with diabetes. To diagnose someone with type 1 diabetes, we use the same glucose parameters, but we also have to consider their epidemiological factors. We also would want to consider if they have other aspects of autoimmune dysfunction that we may be able to pick up. More specifically, we may see that they have low insulin levels, low C-peptide levels, and may have positive autoantibody tests for GAD65, zinc, and isolate antibodies. Now, you may also hear of prediabetes, which is when someone is at increased risk of developing diabetes in the future. To diagnose this, we typically get an A1C that is between 5.7 and 6.4%, but you can also do the other glucose tests in order to assess this. These patients have a 5 to 10% risk each year of converting to diabetes and require annual monitoring. So why does diabetes matter? Well, first and foremost, it puts you at much higher risk of cardiovascular disease, specifically myocardial infarction and stroke. It also is the largest contributor to chronic kidney disease and end-stage renal disease needing dialysis. It can also have effects on smaller blood vessels and nerves in your body that can lead to retinopathy and ultimately blindness, neuropathy, which can cause impaired sensation in your feet and in your hands, and it can also contribute to GI dysfunction like gastroparesis. What symptoms will people have? Well, usually they're asymptomatic, but in cases where they have acute hyperglycemia, they may develop diabetic ketoacidosis or DKA or hyperosmolar hyperglycemic state or HHS. In these settings, they may have confusion, dehydration, vomiting, vision changes, and dysuria, urinary frequency, or UTIs. When someone has acute hypoglycemia, where their blood sugar is very low, they may present with shakiness, lethargy, sweats, or confusion. In the long run, they may also develop vision changes due to retinopathy, decreased peripheral sensation due to neuropathy, recurrent skin infections and wounds, GI upset such as gastroparesis, which can lead to vomiting and diarrhea, and recurrent urinary and vaginal infections. So what are our goal blood sugars? Most of the time, we just monitor patients' A1C every 3 months, and our goal A1C for most patients is less than 7%. However, if a patient is sicker, has a low lifespan, or has had diabetes for a much longer time, you might consider giving them a less stringent goal, such as an A1C less than 7.5 or 8%. Now, we have other ways to measure blood sugar. One way is to do finger sticks, in which case we can look at their finger sticks before they eat and hope for a goal of 80 to 130, or look 2 hours after they eat and look for a goal less than 180. Now, with the advent of new technology, we also have continuous glucose monitoring, where we can see what percent of the time patients are actually at goal. And the easy way to think about it is that they should be 70% of the time between 70 and 180. So how do we manage diabetes? First and foremost, we want to consider lifestyle interventions. The common lifestyle interventions have to do with reducing sedentary lifestyle, getting quality sleep, and doing aerobic and resistance training. When you do these things, you can lower your glucose, your insulin, your blood pressure, and ultimately your A1C. Now, dietary changes are also incredibly important, and there are many diets that have been shown to be effective, whether it's the dietary approach to stop hypertension or the DASH diet, low-calorie diets, Mediterranean diets, or higher protein diets. Weight loss of more than 5 to 15% has also been shown to lower patients' A1C. And because these patients are at higher risk of cardiovascular disease, you should always talk to them about smoking and alcohol cessation. When lifestyle interventions are not enough, we need to consider medications. So there are three first-line agents we typically consider for patients with newly diagnosed diabetes, and especially for patients who have an A1C that's less than 9%. The first class is biguanides, which you'll mostly think of metformin. Metformin is the most commonly used oral medication to start someone on for diabetes, and it can cause GI upset, typically nausea or diarrhea, and in rare cases can cause lactic acidosis. If someone's on it chronically, they are at also increased risk for having B12 deficiency. And as I mentioned before, this is the classic first-line oral medication. Now, one of the newer medications to come to the public's attention is GLP-1 agonists. These include semaglutide, liraglutide, and tirzepatide, which are all medications that act on the GLP-1 and GIP-1 pathways to reduce patients' blood sugar and feel more full. The main side effects of this have to do with GI upset, which is intentional to reduce the emptying of your stomach, which leads to weight loss and decreased appetite. These are typically done as weekly injections, but there is a daily oral option that is slightly less effective. And because of advertising and clear benefits to the heart and to the kidneys, these are becoming the new first line that patients often are started on. Finally, the third first line agent would be SGLT2 inhibitors. These would include empagliflozin, dapagliflozin, and canagliflozin. These are diuretics that cause you to put out more glucose into your urine. So as a result, you may have dehydration. They also are rarely associated with a euglycemic diabetic ketoacidosis, and they do put you at slightly higher risk of UTI or vaginal infections. Now, these are great for heart failure and for kidney disease, but you should avoid them if someone's A1C is greater than 9 to 10%, because this puts them at much higher risk of UTI and vaginal infections. Now, when you can't control someone's blood sugar to their goal with those three agents, you often consider doing insulin. And there are different types of insulin, some that are more rapid acting, like Lispro or Aspart, which turn on in the matter of 1 or 2 hours, versus long acting forms like Detamir or Glargine. And when we think about starting someone on insulin, we typically start with a long acting form at nighttime, like Glargine, before we would consider adding mealtime options like Lispro or Aspart. And because these can lower blood sugar acutely, you should always be aware of hypoglycemia and screen to see if you're overtreating. Now, you may be testing on alternative agents that are less commonly used in the office setting these days. One set of medications would be the DPP-4 inhibitors. These include sitagliptin, linagliptin, and alogliptin. They can cause rare side effects of headache and pancreatitis, and these are rarely used, mainly seen with patients who were started on this many decades ago. Another option is sulfonylureas. These would include glipizide, glyburide, and glimepiride. And because these are insulin secretagogue medications, they put you at risk of hypoglycemia and may cause you to gain weight. Now, these are cheap and prandial options that you give in replacement of insulin. So these are often an oral alternative to insulin that is not quite as effective. Similarly, meglitinides, such as repaglinide and ateglinide, are insulin secretagogues that also put you at risk of hypoglycemia and weight gain, and they are also cheap and done with meals. These are in particular used for patients who are nearing dialysis, as many medications are not available to be used for diabetes for these patients. Finally, thiazolinodiones are another class of medications. One example is a pioglitazone, and these are medications that we typically don't use anymore because they can cause weight gain, edema, fractures, and liver problems. And these are particularly bad in heart failure, but this is often tested on STEP and shelf exams. Now, you should also consider other things that affect people's diabetes. For instance, their CVD risk is the most common thing we need to think about. So in addition to managing their blood sugar, you should also take a look at their blood pressure. And when we treat someone for high blood pressure with diabetes, we prefer ACEs and ARBs because they also have benefits for protecting people's kidneys. We should also consider their cholesterol. And any patient who's above the age of 40 with diabetes should be on a moderate intensity statin with a goal LDL of less than 70. You also want to regularly screen patients for nephropathy with an annual BMP and urine microalbumin. You should also screen for retinopathy by sending them to the ophthalmologist every year for screening. You should also check for neuropathy by doing a microfilament and foot exam every year. If someone is on metformin, they should also have yearly vitamin B12 checks to make sure they do not get a deficiency. And finally, diabetes reduces the function of your immune system, and so every patient is indicated for a pneumonia vaccine. So these are the big takeaways. Diabetes increases the risk of CVD, CKD, and ESRD, retinopathy, and neuropathy. Diagnosis is based on two lab values, usually an A1C greater than 6.5%. Once diagnosed, the goal A1C is usually less than 7% for most patients. Management with lifestyle changes should be reviewed with all patients and is typically done first line. But when patients need medications, the first line medications are usually metformin, GLP-1 agonists, and SGLT2 inhibitors. Insulin is usually reserved when these aren't enough or someone's blood sugar is much, much higher. Finally, management of hypertension, CKD, neuropathy, and retinopathy are crucial for improving outcomes.